Welcome to the Healthcare Intelligence Podcast, Sap. Today, we're really excited to have you join, given that you worked across the latest of transformation in the consulting world, healthcare. I know you're going into something awesome as well. So I just want to get started and learn a little bit more about how you went from BCG senior principal running and then to running SCA Optum to now just wrapping up your tenure at ADH.
Yeah, so I came to the US for business school and I learned quite a bit about healthcare and realized healthcare had a lot of opportunity. And then, so that's where I kind of concentrated as I got into consulting. I was very fortunate to get an opportunity at SCA, which was at that time TPG Capital backed, and took that leap of faith. It was very different, right? Because in consulting, you are basically advising, right? You are not doing the things. Consulting has changed, and there is a lot of actually doing also as clients have become more sophisticated, but. It was very, very different, advising to doing. SCA was a great organization to learn, a very good culturally, very good leadership development skill set. They did really invest in their leaders, which helped me quite a bit in through my transition. So I then came to ADH. I was the first executive hire 5.5 years ago. It was a very young private equity called Assured Healthcare, their first kind of real investment because they had just been formed in July of 2020. They invested in December 2020. And I got the lucky break to join them as the first executive hire to really develop the MSO, scale the organization. And as we were coming out of COVID, if you remember 21 March, this is when I joined. Um, there was a lot of people issues. What I mean by that is, we had lost a lot of good people from front desks and other areas just because, the clinicians were maintained through the PPP programs, etc. But a lot of the front desk, because there was no front desk to we had, everything had moved to telehealth. So those kinds of elements led us that, okay, we had to rehire, rebuild. And when you have an opportunity, never let a crisis go to waste. We said, okay, we are going to do it based on a lot of, or using technology as the backbone of that. So we obviously hired a lot of people, but having said that, we also deployed a lot of technology tools to do that, which helped us to scale in many ways faster. We were fairly integrated platform, a single practice management system on Athena. So those were all good things which happened, and the opportunity to do it because we had this crisis on our hands.
I think one thing we see a lot in GI space is the eligibility and prior authorization is a little heavier than other specialty. And I think COVID was a really good testing ground where you had to make sure everything is clean. Otherwise, you'll be fixing it in the RCM denials front. How did you approach that from an infrastructure standpoint?
I think so. Eligibility and verification is important and has to be reminded. It's one of those things. If you have kids, you have to remind them again and again that you have to do this something. It's the same way you have to remind the front desk, and front desk staffs have a churn. So there is this element of doing the work, having the right platforms. Right. So Athena, you can do eligibility verification. We also had Frisia. We could do eligibility and verification. Prior auth is still separate. And so we did that. And then one of the tough parts of eligibility and verification is choosing the right insurance package. And so we explored a lot of tools because, you could be on Aetna, but Aetna could have 15 different insurance packages based on, who their employer they've signed up with, etc. So it was very hard for the front desk and that's where the mistakes were happening. So we were one of the first to deploy. Athena had this charge capture piece where they took a picture and they could at least predict not to the that this is the insurance package, but get it down to two or three, which was better than trying to choose from 15 to 20, right? That has improved over time where it is now pretty much predicting that one. But when 2 years ago, it was like, okay, there's a choice. So that helped us in at least getting the accuracy of the insurance packages right. Once that happened, and then it became a little bit easier to get that. There is, to your point, a lot of prior authorization burden. So we deployed different things for different pieces. So specialty pharmacy, we carved it out and gave it to a company which is now called Forus, and they do a lot of the specialty pharmacy work, prior authorization for radiology. Because we don't have radiologists in our team, we were like, okay, let's partner with big radiology companies, and we just route it to them, and then they can figure out what is required from a prior authorization perspective, because we are not experts, right? We are not experts, and they can do that. So we did that, did partnerships with a bunch of private equity backed radiology groups. And then from a procedure perspective, we have two elements. Athena helps us, but we also have an internal team, and we do that where we use Athena's platform for anything which is 7 days prior, and then we have an internal team to do a lot of the prior authorization, which is within the 7 days. If let's say you have a procedure in 3 to 5 days, it's very hard for an external organization to do that, where we will jump in and we have a team for that. So real focus, and then things which were not our core, just taking it out and giving it to whoever we could.
When you were implementing these technology, I'm sure there is training and change management involved since a lot of them touch the front desk staff and it's part of different than their usual SLP. How did you approach that organizational cultural change?
I think first and foremost is getting the doctors on board. At the end of the day, um, I am not seeing the patient, right? Even though, like, the front desk staff is, and the physician, we should never forget that why we are all here. We are all here to make the physicians be able to see their patients and get better outcomes for their patients, right? So a lot of it was getting a buy-in from the physicians, even if it was the front desk work, because these physicians ultimately would, if it was not good, they would hear it from their patients, right? So a lot of our change management was creating that dyad, talking to them, because there was a lot of ideas which I had completely got, you know, pushed back, because saying like, why are you doing this? It's not complicated. It's adding more work, all those things. Because so and these physicians, especially in the specialty side of things, they are all business people because they ran their practice before they joined ADH. So they were, really good in understanding the business elements of it. And there are some of the docs who could run, be CEOs of very large companies because that's how much business knowledge they had. So that was very important, is getting the buy-in from the physicians and getting their buy-in, because once they had buy-in, because I personally am not in every clinic, right, which we have. And invariably, we all respect our doctors, right? The front desk staff, the practice admin, they are loyal to their doctors because they see them and they see what they are doing every day. So there's a huge amount of respect. So if the doctors would say that, listen, this is the route we are doing, that was the first step in getting any sort of buy-in for change management. And obviously the teams would complain, right? Change is hard. But getting that buy-in from the physicians is the most important thing, I would say, because if you can't get it, the buy-in from the physicians, hard to make any change in a clinical practice, right? And sometimes we forget, and there's like this top-down push, and then things don't go the right way because the clinicians are not bought in. Why are we doing this? So that was the biggest learning I had.
How, besides, in terms of like, if we get a little tactical around the buy-in, did you bring in new incentive plans? Did you change reward system in any way? How did you put a system in place?
Great question. It was more not incentive plans, but how is this change going to help them in having a better income, patient experience, better kind of outcome, right? So let's use an example of ambient AI, right? It's not just using ambient AI makes the life easier and everything. But it's a cost. It's a cost you're adding of using Scribe, which you were not using before. And so, but what we saw was the notes were better, denials were lower, patients liked it because finally the physicians were talking to their patients, right? And then second piece of it is because the notes were better, we could code it appropriately to what it was, versus many a times insurance companies would push back, not pay us what is owed, even though there's complexity and we're dealing with the patient. So the richness of the note, because of it's capturing the live conversation, helped us to do that. We showed those elements. So then there was a buy-in, and then physicians started to use it, right? And then they said, to the nurse practitioners. Now, not everyone was convinced. There's never this 100% buy-in. That's
There's always skepticism. Makes sense.
always skepticism, but there are sometimes these pioneers who would start doing it, and then the others would see. Same thing when we started using, AI detection for polyp detection, GI Genius. By the way, the software wasn't very good initially because it would have false positives, right? It would create boxes around bubbles in your colon and things like that. But over time, over the last 4 years, Medtronic software has become amazing, right? Because they've learned over the last 4 years. And it showed that the patient outcomes can be better because every time a point of an ADR rate goes in means you're detecting cancer better, right? And that is good for patient outcomes. So at the end of the day, doctors are here to help our patients, and that's what you are blessed with in ADH. So it has to tie in to patient outcomes. It has to tie in to financials. Otherwise, just creating incentives, you will still won't have utilization. Right, and we have seen that, and so on contrary, like for example, when we did clinical research, we tried to create incentives, or if you send patients, etc. But if the physician said that this research is not appropriate for my patients, doesn't matter if I'm paying whatever to the physician, they're like, no, I don't want to send my patients to take an experimental drug because it's not appropriate, right? So incentives can only work if there is. But on the other hand, yes, you give incentives to the front desk staff, you give incentives to all those people to do certain jobs better, or the practice admins or other people operating teams and the members.
How do you roll that out across 85 clinics? Do you start somewhere? Do you do it all at once?
No, you start somewhere because and it's not even like, I don't like long pilots. You start it, implement it, see what happens, learn from it, because it doesn't matter what you roll out, you will find things which will not go right. Right. And so that's very important to do that. So, you roll out those things, do all those things. And, before you know it, like you learn and then you go to the next one, you go to the next one. And once you get a little bit better, right, then you start rolling out at a little faster pace, right? Rather than one by one, because, but never, we are too big, and, healthcare is complex. People have different elements of it. So just rolling out, it'll be too much to manage, and we don't have enough people to then feel all the things which can go wrong.
Makes sense. And then when you grew ADH from like the very early phase in the pandemic to now, if you were to start again in 2026, a new organization from scratch, how would the way you approach it be different?
I came to the realization of the physician buy-in. Um, as we were implementing, I would have gone further and more and really get physician buy-in upfront on a lot of different things. We were very successful in certain things, which was different. The other piece of is workflows cannot remain the same when you are implementing new things. So one of the mistakes a lot of times we would say is like we will take the broken workflow and try to fit into the new technology, right? And it wouldn't work. And there were things which were going wrong. So being very, very prescriptive in the sense, okay, is this the right workflow? Why should it change? Because, one of the things which typically you will hear in healthcare is, oh, it's not broken. Why change? by the way, everyone should know that healthcare is broken, right? We have cost problem, escalating costs, so much administrative waste, right? People talk about 30 to 40% administrative waste in doing things. Um, so that's very important that we really look at your workflows and make sure. And in some cases, looking back, I didn't appreciate that redoing the workflow, and we implemented things and then they didn't go well, and or etc. And then we change the workflow to really say, okay, this should be efficient. So that's very important, that not to just implement it on things which are not going well, like like anything, right?
Yeah, it sounds like, and I think the inertia is to change as little as possible so people are not like shocked by it, but the tax you pay is overfitting it to something that wasn't working that well in the first place.
Yeah, and it was kind of working because people were doing things. Yeah, right. Kind of working, doing things. And so we were like, okay, I'm used to just doing this. But rather than saying, okay, what is the right? Maybe you're doing things which you shouldn't be doing, right? Asking that question, right? Like, oh, you always did that. That's the worst thing we can do, right? In any kind of implementation, healthcare or otherwise. So that's very important.
And if you were to share advice with your peers, what are, in terms of like everyone's looking at automation, potentially a couple of them at once. Um, what do you think is something that's like overhyped that they should stay away from versus think something that's like really working they should lean into now?
I think the issue which is overhyped is that AI will come and just replace all the FTEs. And that's an overhype. I think there's a lot of complexity. A lot of things are not SOP'd, right? There are things which happen, which are in people's mind, and it's not that easy. And the edge cases are a lot in healthcare. Doesn't matter what you take, which specialty or primary care, etc. So so you have to be very, very focused on what fits in your workflow and what technology, etc., rather than saying and promising that you're going to take out, X FTEs and all those things. The other piece of it is, you know, the human labor part is very, very difficult. There's a lot of churn, a lot of attrition. People leave for $1 extra, in that kind of, front desk and RCM and, all those elements of it. So, could be an opportunity. Yes, you can save cost, but can you make it better from a productivity perspective? Or can you use that savings to pay the good people a little more so that they can do more, right? And then have technology to make their lives better. So I think there is a little bit of a thinking which we have done, because everyone I hear nowadays is like, oh, AI will come and replace FTs. And then they realize it's, first of all, hard. And then second, tokens do cost, right? Now that the token,
It's pretty expensive.
yeah, like you start paying for tokens, you will realize it can be as much as the FTE, right? Because earlier the things were free, but these companies are now all here to make money, right? So I think that's the misnomer that, and people are realizing, and just pushing AI for the sake of pushing AI rather than, okay, how is this going to better outcomes? It doesn't make sense.
One thing you said that stood out was like empowering the power user or the people who are using it more, right? Because I feel like with AI, even outside of healthcare, I feel like my job has doubled given how many tools I can use and monitor. Like the idea is to do more for me, but I almost feel like because of the possibility, people just end up taking up more and more. I'm sure the same thing is happening across the board.
Yeah, you have to prioritize, right? You can't not solve world hunger, right? So you have to prioritize what is the highest value, where it's going to drive, and really, really focus on driving two, three things to completion. And the huge prioritization is important.
Yeah. Awesome. Well, Sap, thank you for joining us today. It's such a pleasure to catch up again.
Thank you, Charlene, and thank you for giving me the privilege to talk into your audience. Thank you.